Good evening, dear ESTS members and webinar attendees. As you already know, my name is Lieve de Piepere, your ESTS webinar coordinator and moderator for today. This is already the 6th webinar of the 2018-2019 series, and today will be about malignant pleural mesothelioma. I'm very proud to introduce you to Dr. Servet Bolukbas as a guest speaker. Dr. Bolukbas is the chief of the Department of Thoracic Surgery of the Kliniken Esse Mitte in Essen, Germany. One of his main clinical and research interests focuses on the lung-sparing surgery for malignant pleural mesothelioma. So please, Dr. Bolukbas, the stage is yours.
Yeah, thank you very much. Thank you for this kind introduction. There are a lot of experts out there. I would like to thank the organizers allowing me to give you a presentation about this topic. And a warm welcome to everybody to Essen, wherever you are. Let's start our presentation. I have nothing to disclose.
We can still not see your presentation.
Okay. Share. So, is it okay?
Yes, perfect.
Perfect. I have nothing to disclose. In order to give you a feeling what's going on there in Germany, I give you some figures about the epidemiology. We have about 1,300 cases of male patients with pleural mesothelioma and about 220 female patients. And as you can see, almost all of them die. And there is a very important issue. The 5-year survival rate for female patients are 17.7%, and 5-year survival rate is about 8.6%. As we can see, it's a very rare and dismal disease. And if we compare it to these buses have a capacity about 100 people. And at the beginning of the year, we have 16 buses full of mesothelioma patients. And at the end of the year, only 3 buses left. Therefore, I follow the Hippocrates advice. As to diseases, make a habit of 2 things: to help, or at least to do no harm. Is so bad. Non-surgical treatment options, best supportive care is about 7 months, irrespective of the study from which date they are. If we look at chemotherapy studies, irrespective if it's whether they are chemotherapy doublets or triplets, it's approximately 12 months. Even if the new treatment options with immunotherapy gives us a median survival of 14 months. But be aware, treatment-related mortality for doublet immunotherapy was 5.6% in this presented treatment trial from Servet. There are some particular features of malignant pleural mesothelioma. In solid cancers or tumors, we are used to obtain safety margins. There are definitions. We know what to resect, what to leave inside. But there are no safety margins in malignant pleural mesothelioma. Within a few millimeters, we encounter different specimens like the chest wall, the intrathoracic fascia, the great vessels, the mediastinal organs, pericardium, diaphragm, or peritoneum. That means we can only achieve macroscopic complete resection, especially at the chest wall or the great vessels. At the end of the procedure, we left microscopic incomplete disease behind. Before we go in detail with outcomes, it's important to talk also about definitions. If we talk about outcomes of pleurectomy decortication in multimodality settings, we don't talk about partial pleurectomy. That means you take only a small part of the gross disease out and leave the gross disease behind. We talk about pleurectomy decortication, where we resect all the pleura with the disease. And if we perform diaphragm resection and or pericardial resection, it's called extended pleurectomy decortication. But if we talk about extended resections, in this definition, it's not included if you perform a birdcage procedure or a resection of the chest wall or for the great vessels. Nonetheless, whenever I talk about resection of the pleural diaphragmatic pleura, it looks like this. Only if I can resect the pleura and leave the bare muscles behind, I perform this procedure. Whenever it goes deeper in the muscles, I prefer to perform a full resection of the diaphragm, but keeping the peritoneum closed. At the end of the procedure, the interlobar fissures look like that. You see here the skeletonized vessels from the middle lobe, lower lobe, and the upper lobe. No disease is left behind. Also, if we look at the end of the procedure in the upper mediastinum, we can see the skeletonized great vessels with vena anonyma or cava superior, and you see all the lymph nodes are also cleared out. If we look on the lower mediastinum, it looks like that. All the tumor is resected. We see no macroscopic disease. All the vessels and organs are skeletonized. But if we want to interpret outcomes, we have to know everything goes up and went down with patient selection. 5 years ago, we presented this meso score at the IMIC conference, and we kept it very easy. We used the IMIC stage, it's early disease or advanced disease. We used histology, epiloid or non-epiloid, and we used only age, above or beyond or lower than 70 years of age. And each negative prognosticator receives 1 point. And at the end, we can see if you choose out only the winners, you can end up with 75 months. But if you use the loser, if you select the losers, you can end up with 6.3 months. And you know, it's we can remember Hippocrates' advice: do not harm. Mm-hmm. It means there are different possibilities how you select patients and how outcomes are reality at the end. You can choose the losers. You can choose a cohort of patients where you don't have any advantage against chemotherapy. You can choose patient cohort with very nice survival, and you can choose winners. Before we go in detail, a few words to the history of pleurectomy decortication. For me, this is one of the most important milestones in PD. It was 1991 when it was published by Dr. Brandscheid and co-workers from Heidelberg. By that time, in 1991, they had 301 patients with diffuse malignant pleural mesothelioma, and surprisingly, patients undergoing treatment survived longer than EPP patients. And by that time, their conclusion was that EPP should be performed in very, very limited patient group. Nonetheless, you know, all that EPP was the favored procedure of most of the thoracic surgical colleagues, and the results were quite nice. And if I go back to the ESMO guidelines in 2007, pleurectomy on decortication, as shown here, was palliative local procedure. In 2008, I thought it's the end of EPP because EPP was a negative prognosticator for survival. Nonetheless, you know, there were a lot of publications about EPP, and only a few about pleurectomy decortication. We presented this data in 2007 at the ESTS meeting, and we used the best possible options in our philosophy. That means we used cisplatin pemetrexed as chemotherapy option. The patients underwent radiation of incision sites, and we used only pleurectomy decortication, as I shown before. The approach, we do it, and we ended up with a median survival of 30 months. It was quite nice, but I was always almost beaten up at conferences whenever I presented data, because it was conflicting, because it was surprisingly long median survival. And as shown here, the publication was accepted in 2009, but it was published in 2011. Nonetheless, I cannot show all the publications, but Joe Friedberg's study showed it's not only possible in Germany that you can obtain long-term survival after PD. No, it's also possible in the United States, and you see here very nice long-term survival in epithelial histology beyond 3 years. Just look at the outcomes. Nowadays, the most important issue for patients are quality of life, patients-reported outcomes. If we look at that, we had a patient cohort where we looked at the functional results in terms of pulmonary function and perfusion scans. And these patients had predominantly pleural effusion, underwent the procedure I mentioned before, and we saw they had a better functional outcome than expected. If you look at quality of life after EPP, it's worse after the surgery and multimodal treatment, whereas after PD, there are two groups. The first group, if the patients had no symptoms, they have in the first month worse quality of life, but after that it turns to be better. If they had already symptoms at diagnosis, it turned much faster to better symptom control. And this is a publication from Clunas and colleagues, and he showed if you have PD patients, some do better, some do worse, but almost more or less it's the same functional pulmonary reserves before and after PD, whereas after EPP, the patients have a loss of pulmonary function. If we look at mortality morbidity, this is a systematic analysis, meta-analysis. You see it's in favor of pleurectomy decortication for morbidity and mortality. If you look at this newer publication from the Zurich group, we see they have in their experience 0 mortality after 30 days and 90 days. They have to congratulate for that result, but after EPP, 2 and 8%. If we talk about morbidity, we all try to avoid morbidity. And if you deal with a lot of mesothelioma patients, you recognize the problem of prolonged air leak stops when your decorticated lung gets attached to the chest wall and to the diaphragm. Therefore, we performed this procedure called thoracic shaping technique. That means the reconstruction of your diaphragm replacement is much higher than before, so the thoracic cavity becomes smaller, and therefore it reduces the prolonged air leak phase of the patients. Nowadays, these are pictures from the first beginnings, where we resected and replaced diaphragm and pericardium with Gore-Tex material. But we recognized in this area, there are no attachments. Therefore, we encounter prolonged air leak, especially in these areas. Therefore, we avoid nowadays Gore-Tex material. We use polypropylene material. It's very popular that you use a laser for pulmonary metastasectomy, and nowadays I use laser also for mesothelioma surgery. When is it very advantageous? If you have a lower lobe attached because of the tumor to the diaphragm, if you use standard techniques, you get into the area of the subpleural veins, you have bleeding. You use a lot of wedge resections, the shape of your lower lobe diminishes. You get into wrong areas, so you have damaged lung tissue with prolonged air leak. Therefore, you can use such kind of laser in these special areas where you have a scissoring and sealing of the lung tissue during the same time. I don't know if you can see it very properly and good quality, but it helps you to reduce prolonged air leak also in this
it's okay. We have an idea. The video is quite okay. The video is quite okay. We have an idea of what it is like with the laser. It's okay.
Okay, you can see right here now the diaphragm with the tumor and the resected small piece of lung tissue on this diaphragm. And you can see also it's very fast procedure. I go forward, and we summed up the initial patients and presented last year in IMIC. It was almost advanced disease, and we had very nice effects of this laser, and macroscopic complete resection could be achieved in all procedures, and as expected, median progression-free survival in this very small experience was 16 months, and overall survival, median survival was 29 per month, and we are including more patients to have a better overview of what's going on there. What about oncological outcomes? Lang Lasdunsky from London had a very nice publication about outcomes, and what we can see, it's more or less the same survival what we can achieve between two procedures. As I showed you before, it depends what kind of patients are included in your cohort. If you look at this diagram, it looks to be slightly better for PD, but as I said before, it depends on patient selection. Nonetheless, the smart euphoria was recognized a few years ago. The initial 25 patients showed a 3-year survival rate of incredible 84% with a follow-up of 23 months. Nonetheless, not excuse me, see any median survival because excuse me, after only 23 months. But later on, we saw if you include more patients, you end up with 28 months in this follow-up study from the SMART trial. That means more or less we end up with 30 months, 33 months, or something like that, irrespective what kind of procedure we perform. There is a new paper, unfortunately I had no access to this paper, presented by Dr. Hasegawa from Japan, and he showed very nice median survival. They called it less invasive EPP. I cannot give you the details about that, but they ended up with 42 months median survival, and after PD, after 43 months median survival. As I said before, patient selection. And the other factor might be, of course, biology of the tumors. There is a paradigm shift which we can observe nowadays. There is adoption of PD in formerly internationally known EPP centers of excellence. One excellent center is from Istanbul. This paper was presented by Dr. Batirel from the Marmara University, and you see if you apply PD, you end up with the same survival like EPP. This is the study from the Zurich group. You know, on the left side, you can see freedom from recurrence. That means irrespective what you do, the tumor comes back. It doesn't matter if it's after 13 months or 15 months. And you end up in this study with a median survival of 23 months after EPP and 32 months after PD. There also should be these results. If you look at this study, it's a National Cancer Database report where they investigated EPP and PD. In a matched cohort, you see there is no survival difference. There were some conflicting results regarding macroscopic complete resection. In 2013, we showed if you apply pleurectomy decortication as in an intent to treat analysis, patients undergoing incomplete resection, they do worse. They end up like chemotherapy alone, about median survival about 10 months. Nonetheless, Langlas-Dunsky showed us in his study that patients survive longer than completely resected EPP patients. And to make it more conflictive, here's the study of Dr. Batirel from Istanbul. He showed us if you look at macroscopic complete resection as the primary endpoint, you have no difference in survival, irrespective if you have macroscopic complete resection or incomplete resection. In the unmatched analysis, median survival was 21 months for macroscopic complete resection and 60 months for incomplete resections. 2-year survival was similar statistically, and 5-year survival as well, because 5-year survival rate was 60% in both groups. But if we go in detail, in non-macroscopic complete resection group, there were partial pleurectomy decortications in 47 patients. And if you go to in detail, once again, you recognize that there are also patients included where pleurectomy or decortication was only partially for the purpose of obtaining histology and diagnosis. So the results are a little bit conflicting. And if you look at the mortality, incompletely resected patients had not 0% 30-day mortality, whereas for completely resected patients was 8%, and it was after 90 days, almost 15% versus 3.5%. And they matched these patients, and once again, there are still 47 partial pleurectomies inside the study, and they saw no difference in the survival, irrespective if it's macroscopic complete or incomplete. So what is the role of surgery in this dismal disease anymore after these conflicting results? I like to cite always this study from Atley et al. The colleagues were able to show us a theoretical survival advantage for MPM patients of about 8.5 months. There are also newer studies. Nelson et al. From Houston, they performed a national cancer database analysis on 25,000 patients, and they matched a cohort of 6,645 patients, and they were able to show us. I will show you later on a table where you can see it better. They showed us, irrespectively what kind of histology, whenever you apply cancer-directed surgery, the patients observe better survival. Here you can see it described in a table. The patients undergoing 3-modality treatment in all stages do better than patients having no surgery. As shown here, even in stage 1, patients not having a surgery end up with 13 months. If you can apply 3-modality, 23 months. What does international guidelines give us for information? We can divide the world in North America. There are a lot of experts performing aggressive surgery. Therefore, in this guidelines, you can perform pleurectomy, decortication, or EPP upfront or after induction. Chemotherapy, it's within the guidelines. It's on the discretion of the surgeon's intraoperative findings and his philosophy. If you go to Great Britain, the country of the MAS trial, I didn't want to show you any details about these conflicting results. You see there, they recommend do not offer VATS pleurectomy, partial pleurectomy or talc-porodesis, do not offer EPP, do not offer EPD outside of a clinical trial. It's a little bit different in Europe. There will be an ESTS shortly, it's unpublished yet, and they recommend all surgical patients should be included in a trial or in a registry, and surgery may be appropriate for highly selected MPM patients. This would usually be EPD, performed in centers of excellence as part of multimodality treatment, and they recommend not to operate on sarcomatoid or sarcomatoid predominant histology and 2 disease, excuse me, and or stage 4 patients. So my summary for the management of MPM and pleurectomy decortication would be a quotation of Hippocrates. As to diseases, make a habit of 2 things, to help or at least not to do harm. Please select your patients appropriately. Extreme remedies are very appropriate for extreme diseases. Surgery has its role in MPM management for now and in future. Of several remedies, the physician should choose the least sensational. In my personal view, PD should be the treatment of choice whenever it is possible. And to do nothing is sometimes a good remedy. That means if you have patients with a lot of negative prognosticators, please do nothing because you do harm. Thank you very much for your audience, and I'm happy to answer your questions.
Okay, thank you very much, Dr. Bolukbas. If the people in the audience have any questions, you can ask them through the right sidebar, where you can find the bar with questions, and there we can put some in. Let's have a look if there are already some. I think this was a private talk about the vena cava superior or not. How about resecting these vessels? I think this is really something major to do, and if you can. So the question is, if you resect the cava superior and inferior, and eventually also a part of the what did they say, of the trachea, then you have a radical operation. Can you prevent any recurrences with doing this kind of really extensive surgery, let's say?
No, I think these patients are no candidates for surgery. You can do this procedure. It's quite a demanding procedure for the surgeons. You can be very happy at the end of surgery, but you do not help your patients. The recurrence will be there, and you will do harm to these patients. It's my personal view.
Okay. Then for a biphasic malignant pleural mesothelioma, would you recommend PD? Or for epithelioid, that was clear, I think. And then the other types?
Yeah, there is one prognosticator. If you look at your confidence interval, you can see also in sarcomatoid patients that you have a few patients, they do very well. You don't know why. Therefore, a single prognosticator is, for me, not enough. Therefore, it's a mixture of different prognosticators, and I follow usually my meso score and the patient's preference. He should be aware of the possible risks and his possible advantages from this kind of procedure.
Okay. And then the next question is, do you use intrathoracic hyperthermia or chemotherapy during your procedures?
Not yet, because there are no convincing data out there. There are publications about HITOC included in multimodality treatment, but they end up also with 30 months, 33 months. It's in the range of the best possible outcomes without HITOC. And unless there are more convincing data, I do not perform HITOC.
Okay. Next question here. Do you consider partial pleural resection as a palliative treatment?
No, just talc pleurodesis.
Okay, indeed, first do not harm. After using the laser, do you use any glue for avoiding prolonged air leaks? They say, but I have the impression that when I saw your video, that there's also some kind of sealing by the laser, no?
Yes. We tried Progel. I don't want to make any advertisement for this product, but in half of the patients it worked very well, in half of the patients it didn't work. Therefore, we do not use any gels for avoiding prolonged air leaks.
Okay. And what would be the percentage of people with prolonged air leak after PD?
Yeah, how do we define prolonged air leak after PD? It could not be 7 days, because all would be then with prolonged air leak. I say to my patients before we go into surgery, we don't, if it's just 10 days or 14 days for the prolonged air leak time, but it's not dangerous if you have prolonged air leak, in my personal view. I did not observe any MPM or something like that, and we do not also put them on antibiotics to avoid any infections.
And you let them go home to drain then, or?
Occasionally, yes. We have a different insurance system in Germany. It's not comparable to any other countries. In other countries, you can do it also. You can send them home very early. It's not possible in Germany. If you have a major surgery, you have to keep them in median 15 to at the hospital. If you leave them too early at home, they cut your expenses. Therefore, we do not have really problem with hospitalization of the patients.
Okay, I understand. Then how far were we with the questions? Do you always resect the diaphragm?
Not always. When it's only required. If I can only do a partial diaphragm resection, or in best case scenario, only the diaphragmatical pleura, it's okay.
Okay. Because another person is saying here, if you resect the diaphragm, you may cause spreading in the peritoneal cavity, but you always let the peritoneum intact if you...
Yeah, we try to keep always the peritoneum intact. Sometimes you have a small hole, we suture it right after this damage of the peritoneum.
Okay. One person is saying, I did not understand why, where did you use the laser? If you have any lesions going into the lung, into the diaphragm, that was the idea.
There are two possibilities. If you have the feeling that there is an infiltration of the lung, you don't have to do wedge resections there. In this case, you have more functional tissue which is damaged and removed. Or the second scenario is between the lower lobe and the diaphragm in this area. Usually, if you try to get rid of the rind of tumor from the lower lobe, between the lower lobe and the diaphragm, you get into the subpleural veins, then you have a lot of bleeding. If you go deeper and you use wedge resections, after several wedge resections, you have more or less a ball instead of a lower lobe in usual shape, or you have prolonged air leak because you have too much damage in the lower lobe. Therefore, we use in this area especially the laser.
Okay. Do you always perform a reconstruction of the diaphragm at the right side? Is the question here, because the liver is there.
It's questionable if you use it in all patients. We usually do it, but we had also a case where we guess there is an infection and we removed this diaphragmatical patch and everything went fine.
Mm-hmm. Okay. There's a lot of questions coming in, so I'm looking to the table where we are now. Do you see clinical situations like a very thick peel when you can not prevent pleural decortication, or where you can see that pleural decortication is not possible? Would you do this in those cases? Is a question. I don't get the question actually, because it's a very.
If you have a very big rind, if you have a very big rind of tumor, usually you have also a frozen chest and very small intercostal spaces. In these situations, if you try to get into the chest and you see it's very hard to get in there, you can be sure that it's also very hard to get this tumor peeled off the aorta and the esophagus and all the other specimens. Therefore, I would stop performing surgery and would perform no EPP in this case.
Okay. And to come back on the histology, would you operate on a young patient with sarcoma with histology? I think your answer will be yes. If there's...
It's very difficult to answer. There is no correct or false answer. It depends on the preferences of the and the risk of the patient, if he's very risky, and if he has, beside the sarcomatoid tumor, positive prognosticators. Yes, I would do it in a very young patient.
In that point of view, I would like to ask the question, do you still see any indications for EPP? I mean,
whenever we plan a surgery or and go through the written consent with the patient, the option of EPP is always inside this consent.
Okay.
But in the last 10 years, it was not necessary to perform EPP, most probably because of the patient selection. Whenever we select a patient for PD, it worked.
Okay. Okay. So, or you have your operation PD you can do, or you stop during the operation because there's some kind of irresectability. That's actually what you. Okay. After surgery, do you recommend adjuvant chemotherapy or radiotherapy? I think there you mentioned the 3 modality. It's very important to reach the numbers, but you can comment on that.
Yeah, I prefer upfront surgery, afterwards systematic treatment. Nowadays also immunotherapy. do not apply prophylactic radiation therapy anymore for a couple of years. You know, there are conflicting studies out there, one's in favor of preventing seeding in the incisional sites, and there are other studies and meta-analysis showing no profit for the patient. And we stopped performing prophylactic radiotherapy, because once you have applied prophylactic radiotherapy and you have a recurrence, then the radiation oncologists do not prefer a second radiation treatment on the same side of the chest. Therefore, instead of giving 21 rats prophylactically, we keep it in backhand. So if there is a recurrence, we can go for 60 or more rats for recurrence treatment.
Okay, so your treatment is upfront surgery and chemotherapy?
In best cases, yeah. If you have advanced disease, we start with induction chemotherapy and just to look if there is any response to this treatment. If there is no response, we do not offer surgery in advanced disease.
Okay. And the recurrences you mentioned, if you have I've seen in some patients with very local recurrence, then you go for radiotherapy, not resection.
Resection is a preferred option if it's the chest wall.
Yeah.
For sure.
Okay.
But if it's in the mediastinum, we do not go for second surgery.
Okay.
Once recently we had a case where we had mediastinal lymph node metastasis on the left side in position 5 and 6 after EPD, and we performed a hemiclamshell and cleared out all the mediastinum. It worked fine, but usually we do not prefer surgery if it's in the mediastinum.
Okay. And then interesting question about the staging procedures. We didn't go into that yet. But would you recommend to explore the abdominal cavity through laparoscopy? Do you do mediastinoscopy for all patients? How do you do your staging procedure?
I do not accept EBUS, TB, and I specimens for the diagnosis. I do not accept also CT-guided punctions from this tumor. I always prefer thoracoscopy.
Okay.
For the final diagnosis of the tumor, and also for intraoperative staging. Is there a possibility to get a complete macroscopic resection or not? If there are any signs in the abdomen that there could be a spread into the abdomen, yes, a laparoscopy. Yeah. But if I have no signs, then no laparoscopy. And whenever it's possible, it's difficult in Germany. We prefer, of course, PET-CT scans. Okay.
Mediastinoscopy?
No. No. EBUS. In this case, if we have a diagnosis, it's only to show or find tumor cells or not. EBUS is okay.
Mm-hmm. Okay. MRI?
MRI, whenever we have a risk of infiltration of the great vessels or mediastinum, yes, MRI, but not routinely.
Okay, and the chest wall? MRI for the chest wall?
Chest wall, it depends on the findings you have. If you have the suspicion that there are multiple infiltrations of the chest wall, yes, otherwise not.
Okay.
Not routinely to rule out any infiltration of the chest wall.
Okay. Then a question difficult to me. What is the role of targeted molecular pathways in the primary surgery or in the recurrence?
I have no data for that question. The future will show us if we find better drugs than we have nowadays. And as I showed you before, the data is not makes me not happy. Mm-hmm.
Does it make sense? That's another question. Does it make sense to perform debulking surgery after you find a staging upgrade during your surgery? So if you see, or when you, I think this person means when you see that this is irresectable, is it of any possible advantage that you try to debulk as much as possible, knowing that you'll have macroscopic incomplete resection?
It depends on the intraoperative findings. If we talk about upstaging because of encountered lymph node metastasis, especially intercostally, it's possible, paravertebrally intercostal lymph node metastasis, I would perform the surgery and go for macroscopic complete resection.
Okay.
If I can go for surgery and achieve almost complete macroscopic complete resection, only a small, good, remarkable error where I can mark it and it could be radiated afterwards. Also, surgery resectability at the beginning of the surgery, I would not perform debulking surgery and stop surgery, so do not harm.
Okay. So when you have, for instance, two places where it seems to be stuck in the chest wall, you will take these places out?
Yeah, I would resect it.
Okay. Then another question. Yes, your opinion about hyperthermia, we already said. There's not really evidence right now. What are the rates of the positive biopsy in patients with a suspected tumor? Would you repeat histopathological diagnosis? Indeed, sometimes it's very difficult to have your diagnosis in some patients.
Yeah, I would recommend redo thoracoscopy to obtain more tissue.
How does it work in Germany? In Belgium, for instance, we have a mesothelioma panel where you have to send your pathology specimen to the central pathologist of that panel, and they come together and they have to be agree on the diagnosis before you can do anything.
We do not have such kind of panel which gives you the advice what to do, but we have reference pathology in Germany, in Bochum, where diagnosis can be sent for second opinion, and they perform the necessary work and clear your diagnosis, or they are in doubt that it's malignant pleural mesothelioma.
Okay.
And they have the last, this is the last instance in Germany.
Sorry?
There's only a second and last instance. The reference pathologist in Bochum, it's the last instance in Germany.
Okay.
That means they decide if it's mesothelioma or not.
It's like the panel, actually. Yeah.
Yeah.
Have you ever used the Aquamantis system? So it's like the kind of bipolar system, radio frequency system for hemostasis during surgery?
I saw this device 2008. Raja Flores was using it during his surgeries, but I personally have no experience.
Okay. What do you use for your hemostasis? Do you use anything? Sorry?
I use usually the laser.
The laser. Okay.
If you use the defocused mode, then you have a very nice hemostasis.
Okay. And then what do you think about targeted therapy in mesothelioma? Is there any?
No convincing data yet.
Okay, I'm looking. Yes, you start your presentation with a very remarkable slide. The survival of males 8.6% and females 17.7%.
Yeah.
Can you give any comment on that?
Yeah, it's most usually the males in Germany, they have occupational asbestos exposure, or they worked at their home doing some work at their homes. But the females, they do not hardly know where to get asbestos exposure. And usually the females have very low tumor volume compared to the male patients. This is one possible explanation, but there is no real workup to
and
find
this was
out
the whole group, I think. So also in the surgically treated patients, you see the same numbers.
we see that females do better, but not that different.
Okay, interesting. I think we're out of questions. We have this webinar already for 15 minutes, so this is very good. I don't know if you want to give us some kind of advice, or if you have any questions for the audience.
My advice is to follow Hippocrates rules. It's almost a couple of 1,000 years old, but it's still up to date. And my interest would be, we have for sure colleagues from different countries, and what their approaches nowadays with these conflicting guidelines. Each country has different advices, different guidelines. We don't know how to present these different. It would be interesting to hear or to read the experience of the different colleagues out there.
Indeed. Okay, then I would like to thank all the people in the audience to watch this and to be very interactive with a lot of questions. I think we had about 70 live attendees today. Thank you, Dr. Bolukbas, for this very nice overview and speech of your practice and the guidelines in Germany and more internationally. I would like to invite all of you to our next ESTS webinar, and this will be on April 24th, not 22nd, because this is Easter Monday, and it would be a problem in some countries to have a lot of audience. So we will skip this to the Wednesday, the 24th, and this will be about safety protocols in the OR. Okay, thank you, everyone. Thank you, Dr. Bolukbas, and see you next month.
Thank you very much for this pleasure and opportunity.
Okay, bye, everyone.
Bye.